We're going to focus this discussion on COVID-19 and how it's impacting orthopedics. During this WebEx, you will have the opportunity to hear from your colleagues as they share their experiences navigating this crisis thus far and explain how it has impacted the sports medicine practice. At Conmed, we feel that we had the unique opportunity to arrange a forum for discussion on this topic for the customers that we serve on a daily basis, and it's our pleasure to coordinate efforts to bring this conversation to you today. Dr. Abrams, at this point, I'll go ahead and pass it over to you for an introduction. Would you like to say a few words, and then all of our panelists and presenters can introduce themselves?
Good day. I'd like to thank Conmed Linvatec for this opportunity. This is a very unique time in our lives where some of us are sitting in our homes, not at work, which would normally occur at this hour. We've managed to try to get a bit of a window of what our future may be in the United States. I'm about 1 hour from New York. The effects of New York are already entering my hospital. It's been partially closed. The other speakers will introduce themselves shortly and tell you a little bit about what may be their circumstances in the United States. And then we're very fortunate to get a window of what may be next week or the week after or potentially even the next month as Dr. Castagna and Professor Kim will reflect on northern Italy and Seoul, Korea in terms of what may be our future until we can maybe be better prepared based on their presentations and questions from you. So I'd like to let each of the speakers introduce themselves to you. I'm basically in shoulder, but there are other specialties being represented here to make sure we have the playing field covered. Alex, can you introduce yourself?
Okay, I'm the next. Thank you, Jeffrey, for the introduction. Yes, of course, I'm speaking from Italy, so we have 6-hour differences from Florida or Eastern United States. And I am a shoulder guy. And most of all, I am Italian. That seems that we are really the most involved Western country in this terrible state, COVID-19. And my job is to be, I'm of my service in my hospital, and I will tell you the experience later on. And I am also a full professor of orthopedics at the university and director of the resident program in the University of Milan. So you have residents to take care of, students and patients. So this is quite interesting because I'm wearing a kind of 2 hats and facing 2 different problems or these different scenarios of taking care of the patient orthopedically and going on with the teaching and research activity.
Jorge?
Self-presentation, is that right?
Thank you, Jeff. I'm Jorge Chala. I'm an orthopedic surgeon at Midwest Orthopedics at Rush and an assistant professor at Rush University Medical Center here in Chicago, Illinois. I'm originally from Argentina, and I lived here in the States for 5 years now. Thank you, Conmed, and thank you, Jeff, for putting this together. I think this is a great opportunity to see the future now from our colleagues from Italy and South Korea and try to understand how to best manage this uncertainty and these times that we have to live that are certainly unprecedented for us. I just wanted to thank our colleagues from both the States and also from Italy and South Korea for taking the time doing this and inform so many people about how to best manage these times.
So my name is Jingu Kim. I'm from South Korea. So maybe now this is 10:40 p.m. in Korean time. So thank you for inviting me to share our experience to whole world. So we already experienced 10 weeks against the COVID virus. So, 10 weeks is a very long time and a very painful time. So we already passed very different 3 stages. So maybe we can share our experience. Maybe I want to share our experience can help you overcome this virus. So my hospital is partially private, partially for the national designated hospital. I'm working as a hospital president now, so I can understand our national strategies to fight against COVID-19. So I can share my experience and how we can restart our orthopedic practice now. I finished the night operation today. This is 2 months of painful waiting and reassign our facilities. So we started now. I'm very happy.
And Tom?
Yeah, hi. So I'm Tom Wirtz, hailing from Boston, assistant professor at Tufts Medical School. So I'm in private practice and academic practice. You know, I think compared to New York, and as Jeff mentioned as well, we're maybe a week behind from, I expect a wave coming up here. So yeah, private practice has certain challenges as well. Obviously, with our staff, we unfortunately had to lay off quite a few people because we can only do elective cases, so our revenue is significantly down. In terms of academics, yeah, the research, you know, there's a flurry of research activity going on online and offline now, so it's great. We have more time. There's not clinically that much going on. But yeah, resident and fellow education is obviously a challenge currently. So I think I want to thank everybody for joining. Thank you to Conmed for setting this up. Dr. Abrams, thanks for kind of moderating this. And I'm really looking forward to hear from my colleagues and from all of you who are online as well, other colleagues throughout the world, what their experience has been and how we could maybe help each other some information and getting a good look at what happened and is happening in Italy and in South Korea. So looking forward to a fruitful and good discussion with everybody. Thank you.
Thank you, Tom. I think to start off, maybe Alex Castagna can give us his experience from Milan, which, as you know, northern Italy seems to be the epicenter of Europe for difficult times. So, Alex, if you could get us started.
Yeah, we are really in the middle of the battle of the war, I should say. Thank you, Jeffrey, and thank you to Conmed for this beautiful idea to share opinions and experience. Very little is known about this kind of infection, and starting from China when it was originated and reaching then South Korea and Italy and now spreading all over Europe and now moving from east to west somehow. And this is something that is involving the entire world, we can say. And because the borders are not respected by the virus. And it is very important, especially for my friends, colleagues in the United States, do not underestimate the problem. I will just simply report what happened to us more or less a bit more than 1 month ago. 1 month ago, let's say 40 days ago, just 1 or 2 cases were described on a young gentleman who was just working with a big company and at meetings in Munich, Germany, where there were some Chinese representatives too. So he went back to Italy after this meeting, a sort of weekend meeting for work, like we do many times also in our job. And after 10 days or so, he started having the symptoms. And then the diagnosis of a COVID-19 was done. But at that time, he was moving around this little village that is not very close to Milan, but not in Milan. So very shortly, that little village was isolated. But this is important. It was underestimated that the virus could spread more and more and more. So red zone for this little village, but no red zone for Milan, for instance, or the entire Lombardy, that is the region around Milan. That is the most crowded, most active, with a lot of factories, companies, and activities. So people are moving back and forth and from all over Italy and Europe. So at the beginning, this was limited there, and apparently it was just enough. But it took about 10 to 12 days to see how it was exploding there. And I should say day by day, the government was slowly, not fast enough, but they adopted the same indication that were coming from Wuhan, China, and from, of course, Korea and the countries that were experiencing this problem for us. And so what happened in the real life and how it was affecting our daily life. My surgical activity was completely stopped. From, let's say, March the 1st, I go by memory. I remember that they started stopping elective surgery, just letting us doing urgencies. So my last surgeries were only prosthesis on fracture or fracture synthesis and fixation. This was the last few surgeries that I did, let's say 15, 20 days ago. But no more arthroscopy or Latarjet or elective surgery was completely stopped. By the time, they also introduced reduction of the office consultation, and after a few days, they locked it. So I'm not seeing any patient anymore. And this was on the side of the hospital activity. Because my hospital, it is a big hospital with a lot of different services, was totally dedicated to take care of the COVID-19 patient. So they locked the theaters also because they need the system, how do you call them, for respiration, assisted respiration? And they needed all the tools, how do you call them?
Ventilator.
Ventilator, thank you, sorry. And so all the ventilators were needed for this. So they just adopted all the ventilators of the theaters wherever, all the anesthesiologists, all the people expert in this. And finally, the government of the Lombardy decided to divide every single hospital to be COVID plus one single major topic where all the patients were concentrated. And our hospital was designated to be a hub for the stroke, while another hospital was for heart attack, another hospital was for the trauma. So practically no activity for orthopedic surgeons unless the very rare trauma, but of course very occasionally, because officially all the trauma were diverted to another specific hospital. So no activity for this. Then the tide was mounting so much that I received official request to provide support for the checkpoints, because every single person entering the hospital that has different buildings needed to be checked for the temperature, a short clinical history before entering, and double checking, of course, that they clean their hands, they have the mask, of course, these are basic things. And so all my assistants, senior and junior, were involved in this, and also the resident on a voluntary basis, they were involved into this kind of supporting activity. Then phase 3, the number was so high that they really needed to have some assistance, not of course for the ventilators where you need specific training, but to be in the wards where the people were staying and taking care of it. So my assistant and senior assistant, they had a very short 3 days training about how to manage basic things related to the COVID-19, and they started to work in the hospital wards for this. Although they were orthopedic surgeons, they were just supporting, not doing any major activity, but support. And we are still in this phase. So no surgery, no seeing patient, supporting the major activity that is protecting patient involved by this terrible disease. And we are maybe seeing the light at the end of the tunnel, as we used to say, unless it is not a train, like somebody said. But anyways, because in the last 2 or 3 days, we reached a steady state and the numbers are declining. That means that, of course, you know, it is more or less a 2 weeks period. I think that Dr. Kim will make a report on this much more detailed. So if you observe this, that in 2 weeks or so, you have a declining of the numbers, this means that the system is working. We were very somehow lucky and at the same time unlucky, egoistically speaking, that this was happening in northern Italy that is the most industrially active part, but also with the best hospital and facilities and blah, blah, because southern Italy is minimally involved. And this is important because they are less organized than in northern Italy. So although it is a problem for us, maybe it is better for the people. It is a dangerous infection, because personally, I lost in the last 10 days 4 friends or relatives, for just myself. That means something very close to me. And it is not totally true that it is involving only elderly people, senior people, because one of my friends who passed away was 56. It is terrible then. So please do not underestimate this. Be very, very, very careful from the real beginning. Do not wait to let it explode, because we have 2 days that your nose tests are not giving you any information, but after 2 or 3 days, you may lead your with the flu-gate droplets, you may lead this virus all around. So be careful and do not listen only to the officials, like the governments or the politicians. They think too many different things. It is a medical issue, and it is a dangerous one. Then going to the university, immediately all the lectures were stopped and the campus was closed to a normal activity. And then we started doing this by remote. This is partially manageable. I did test to the students using the same kind of tool we're using now. I gave lectures, and I tried to involve all my residents. I mean, the residents, they want to have surgery, seeing patient. That is impossible. So I just developed some studies and some research and calling the patient and so on in order to keep them busy. But so in somehow you can really manage the university side partially, and this may eventually change the future also. We will do this activity. But anyways, hospital is for me locked down. We don't do any surgery, elective surgery again, and only the emergency surgery, very little for trauma. And again, just be careful because it is dangerous. And our government told us that at least we will stay in this red alert, DEFCON 4, the highest level of defense, probably till the end of April. And
Alex, I have a question.
Yes, sure.
Sorry. Just a quick question, and then I can wait till you're done if you'd like. Sorry to hear about your close ones. What do you think is the first step after the lockdown from your perspective, from a doctor, orthopedic surgeon perspective? What's the first step?
Orthopedic surgeon, you mean? Well, I strengthen the intercommunication with the patient using these remote possibilities that technology is offering to us. My physiotherapist created immediately, that means 1 week later, a system to be called and then to give response with some videos and advices over the internet. This is for the post-op. That is quite important. And I spent a few hours every day on the computer returning some answers and using, again, internet and so on to provide information. Of course, it is not a full assistant that you can provide, but anyways, it is something that is helping the people at least not to feel lost or alone or forgotten.
Thank you.
Dr. Castagna, I have a few questions that are coming in from our attendees as well.
Yes.
One question, what screening tests or images are you performing on admitted patients?
Well, there was a lot of discussion because nobody knows exactly, even the specialist. And since I am an orthopedic surgeon, I'm not a doctor, and less of all, I am not an infectivologist. But anyways, if you look, it is also probably published in the United States. The specimen that you can have giving you a response about the COVID infection, it can be listed into different levels. If you take a bronchoalveolar lavage fluid, you have a positive % 93. So it is very, very good. So you should aspirate this fluid from your bronchoalveolar fluid and then detect it. And if you use a fibron scope with a brush and take a little biopsy, it is only 46. So 1 out of 2 is negative, but they have the virus. Sputum, I don't know if it is the proper word, is 72 positive. The nasal swabs, 2 out of 3. So it is not totally giving you the full information about it. And if you take a swab of your pharynx, it is only 32%, 1 out of 3, and then we don't have any other important thing. Most of all, also, since the positivity of the test is related to the concentration of the antibodies to the virus, it is not immediate positive. So there is a time span between you get the infection, you start developing your antibodies, and then you become positive. But from time 0, you may spread your virus. This is what I understood reading something and listening to people and so on and so on. So again, what we do on a regular basis is just the nasal swab, but we do this not to everyone, because at the end it may not help completely, but we do to the people with are coming with some minimal symptoms. I say we, not me, but in the hospital. These are the instructions that we received, and also because it is not a matter of this of the test only, but it is also a matter of the capability of the labs to elaborate all these tests. So this is what we do now. I would be very much interested what was done in South Korea. They did very well on that.
Alex, this is Jorge Chala. I'm sorry for your loss. Let me ask you this. At the beginning of the process, when you were going to see patients, post-op patients, what type of equipment or PPE do you use, or what was recommended after you guys saw that this was serious?
I personally, but this was a personal thing in the very, very early phase, the very early 2, 3, 4 days, I immediately adopted the mask, the FFP3. That is the FFP2 and 3 are the best, say 90-95% of protection from the virus, and most of all cleaning my hands, not shaking any hand anywhere. I immediately cut off to 30% of the office consultation, so there was never a crowd in the waiting room or also in the lobby or wherever. My secretary, my assistants, everybody was wearing the mask and scrubbing the hand with these disinfection tools. I adopted this immediately, and this was then in a few days compulsory for everyone.
What type of care do we have to have when you go back home? Let's say that we go and see 2, 3 post-op patients in clinic, and then at least us, we're doing as much telemedicine as we can, but sometimes we have to go to the hospital for a fracture or something like that. What should we do when we go back home?
First of all, my dear, I'm not the Bible. I'm just reporting what I'm living, and I have the same fog in front of you like everyone, probably all around the world. Said that, I will adopt the same protection and principle that I did before the big crisis. So I will protect myself. That means also protecting others. So mask, washing your hands, not washing but using disinfection system. And these are the basics. And staying at distance and avoiding any crowd for any reason. Whatever it is happening or any emergency, no family members are admitted in the hospital but the patient.
That makes sense. Thank you, Alex. Sorry for your loss again.
No. That's why we are here. This is why we're here. But again, please remember, I'm just reporting an experience that sadly it is the worst and may help other people, but I don't have answers. Never forget that nobody is, and I am an orthopedic surgeon. So I just simply report things. So I'm not thinking I'm teaching you something. I'm reporting an experience.
Alex, this is Tom Wirtz. Thank you for sharing your experience. Also, sorry for your loss. I might have missed this, but when we were talking about the bronchoalveolar lavage, is there antibody testing being done in Italy from some of my colleagues in Germany? So I'm half German, so I'm originally from Germany, so I'm in touch with them. They're starting to do some antibody testing as well to see if people have possibly developed some immunity from this, and questioning if one can go back to work. So is this something, just based on your experience, you heard, or that has been done as well?
To my knowledge, no. I should say that virus is different from bacteria. And of course, it is different, but can be linked in weakening the entire system of the self-defense of the body. But I'm not aware of nothing specific, so I cannot give you an answer.
Thank you.
Hello.
Dr. Castagna, I have one more question, and then I have a few people in the audience that we're hoping to come off of mute and contribute as well.
In the background, I lost your voice.
Can you hear me okay, Dr. Castagna?
Yes.
Okay, perfect. I have one more question, and then there are a couple people that I'll pull off of mute to contribute. With knowing what you know today, would you have done anything different in the first few days while you were still getting patients to see you?
Yes, but not myself. It should be done by the public administration, immediately warning people, immediately adopting, preventing attitude in a very strict and severe way. This is the weak point of democracy. Sometimes we spend a lot of time in some discussion and brainstorming and thinking and listening to the interest of companies, factories, jobs, and so on. That is, of course, an issue. But we should decide quickly, because the virus is not waiting for the bureaucracy. So not personally, nothing different. As soon as I got the feeling, I adopted all the possible issues. I closed my personal office, not the hospital one, before the hospital. So I took my decisions, but they were not yet official instruction from the government. So I should say that our politicians should be a little faster, but if they are not, we must be smart enough to be faster than their decisions sometimes.
Thank you. Okay, so we have two people that are going to come off of mute to contribute, and then we will move on to Professor Kim's presentation. So Bruno, I'm going to go ahead and unmute you now.
Hi, hello everybody. That's perfect. I'm Bruno Capurro. I'm working in the hospital clinic in Barcelona. We are also a national reference center for COVID. I just want to add two good ideas that we make in our service. We make, at the beginning, 3 different teams. Every team work in 1 week, and the next week it doesn't work, to avoid crossing the infection, because a lot of people can cross in the middle. And even that, we have a lot of doctors also in our department, then they have the family with this infection. So now we have just 2 teams working totally separately in the week. Also, something that's really important, that when you do a surgery, it's really important to use double or suction to prevent. We do all tests to the previous surgery for the trauma emergency, because also this patient go inside the the hospital and then can get the virus inside the hospital, because now everything is going around to COVID. And also, I want to add a really good experience doing the telematic visit, just calling our patient to our hospital. The people really love that you call, and they feel really well. So that's the only thing I want to add. Give her the opportunity.
Yeah. I agree. I forgot to say this. All our supporters, like that I described, including my assistant and my resident, they have rotations. They do not stay forever. They have a period, few days, and then few days off. And there is a very active calling back service, and we also participate in that. And I agree, it is very important because people, they feel lost. They're at home, they don't know what's going on, and so it is very important. I agree. Thank you for pointing it out. Thank you. Gracias.
Okay, and one more person is going to contribute. I'm going to pull you off of mute right now. Okay, Osama?
I think you can hear me now. My name is Osama Audat. Yeah, I'm an orthopedic resident in 4th year. I work in the Ministry of Health in Jordan. I'm part of the infection control of the Ministry of Health, and I want to tell you about our experience in Jordan. For the past few days, my hospital I'm working in is completely transferred or changed into a corona center. So basically, we stopped accepting any patients at the emergency. It's only for isolation. We shifted every patient now to the other hospitals. In one hand, we have the Jordanian Medical Association. With the Ministry of Health, they did a very nice thing. With the ambulances now, they are sending the doctors, the GPs, with the ambulances to the patient's home, so they don't have to go to the emergency room, so they don't get any infections. So they are treating the patients in their home, fully equipped, and unless the patient needs a surgery. So basically, trauma now really decreased in our country. So we are working trauma patient, and we consider every trauma patient as a coronavirus until proven otherwise. So there is a book, it's called The Handbook of COVID Prevention and Treatment. It's about clinical experience for the Chinese people. And it has a very nice preventive technique, especially for the surgeries. So we orthopedics, we go for surgeries in trauma. So they have a very nice protocol about protecting yourself as a surgeon, how the negative pressure should be in the room. Everyone should be wearing double gloves, the N95 for the surgeon and the scrub nurse. So they have really very nice information. I really would love for every one of you to read this book. It's called The Handbook of COVID-19. The last thing, the elective cases, we really don't have any more elective cases except for the relapsing cases. For example, in the pediatric orthopedics for the TEV, clubfoot, they have to have serial casting. So we have special cars that are equipped with the cast, and they go at the home, they do the manipulations, even in the tenotomies. So these minors, we are doing it in homes. The last thing we have in the north, we have a breakout of one of the cities, and they had a lot of cases. So they locked down the city completely, and it was isolated. So I think we, as the healthcare providers, we are, I think, the people who are transferring or helping the coronavirus to spread. So we have to take really precautions. We have to take care. We have to consider every patient is a coronavirus until proven otherwise. We should protect our families, our friends, because we are really spreading the infection. And that's all. Thank you for joining.
Thank you also for this note, because I have this book. This was distributed to every one of us in a telematic way. Just we have a link, we can click on it, and we have this wonderful book with all the instruction. I'm checking on my email, because maybe it is possible to have it in English too. In this case, I will send it to Erica, and then Erica, you can distribute to everyone, or you can do the same if you have a link, a colleague from Jordan. But this book is very special. Now, while Dr. Kim is talking, I check if I have this also in English, for the link that you can download it.
Thank you. Yes, I'm happy to share that after this call, no problem. So while I pull up the presentation for Professor Kim to go through, there's one more question for the group. What are the PPE recommendations in unavoidable trauma surgery as ortho is potential aerosol generating procedure?
Erica, so I've done a number of fracture cases. This is Jeff Abrams. My concern is, you wear masks in the operating room and you got your sterile gear, but that's to protect the patient from you, not necessarily the other way around. So when possible, the headgear that's done for shoulder replacements may be considered. You don't necessarily want the fan on inside the hood because you can be actually bringing air in that you don't want to bring in. So I think you need to be excluded from the aerolized potential viral transmission, because it's not just the blood components that you're worried about. It can be actually I don't know the answer to the question, if whether or not blood and serum from inside the body could also be a potential, but we have to assume it is. So you need to be more protective of yourselves because of the potential patient-to-you spread. And as the doctors on the phone have already said, you have to assume the patient is either a carrier or has COVID-19. Make that assumption every time.
Thank you. Professor Kim, please feel free to let me know when to move through the slides, and I'll have you go ahead and start your presentation.
Okay, thank you very much. Hello, everyone. Thank you for inviting me to share our experience. So I briefly prepared a presentation for the experience of Korea. So first of all, can I operating it? So let me introduce myself. I'm Jin-gu Kim. So I'm a president of Myeongji Hospital now, and also professor of orthopedic department. Next. Can I handle it? Okay, my major is knee surgery.
I don't know if it will allow you to switch through the slides, but I'm happy to do it for you if you just say next, if you can't.
Just to say next. So maybe my major is root tear, transplantation, and many other ligament surgeries. Next. So I published many papers regarding the root tears. Next. And to present my presentation for every international meetings. The next. And the good collaboration with the Mayo Clinic, Aaron Krish. And there's more than 10 publications regarding meniscus transplantation. Next. With more than 500 cases until now. Next. So I want to move to my hospital, Myeongji. So this is our destiny. We are very close to China. So every virus or any infection from China is immediately spread out to Korea. So we are always aware of this new infectious disease. Next. So my hospital is located in northwestern part of Seoul, and our hospital is some central hospital for trauma and infectious disease for national designated hospital. Next. So next, so I was invited as a hospital president from last July. So I have only 9 months of experiences. So Myeongji Hospital has 7 branches with good Mayo Clinic network. Next. Next. So I will move on very quickly. We have some emergency center, so we are very keen interest about the trauma now in the COVID crisis. So how we can separate between elective surgeries, emergency for the confirmed COVID patients. Next. So next. So this is our statistics. So before three weeks until 3 weeks ago, Korea is number 2 countries who had confirmed COVID-19. We have almost 9,700. I cannot tell you 10,000 patients because we have around 3 or 4 days left to reach the 10,000. Next. This is our statistics. So starting from end of January, we maintained very successfully for 4 weeks to confine the COVID virus with 30 patients. So during that days, there is 0 patients for 4 consecutive days. After that, we have some very troublesome epidemics. Only one crazy pseudo-religious people spread out and infected 10,000 people within 2 days. So until then, we underestimated this COVID virus. This is so weak and very not so fast spread out. However, after we experienced this disastrous epidemic, so we changed our mind and we changed our policy to meet with the COVID virus. So this is a small area, but only 10% of the population of Seoul, they experienced 6,000 COVID confirmed patients within 2 weeks. So this changed the Korean society a lot. Next. This is the Daegu area that is 6,000 confirmed cases within 2 weeks, comparing to Seoul area with 25 million people. The incidence is less than 10 at the time. So now this confirmed case is gradually increased. That means even Seoul and other South Korean area is begin to have some community infection, but its speed is not so fast. Next. So this area is very specific. So because of some pseudo-religious worship, so they shout, they and share within very close societies with more than 1,000 people. So virus loves these kinds of situations. So until that time, we underestimated the COVID virus. So we changed our policy. Next. So this is our strategy for 4T in Korea: trace, test, triage, and treat. So first is trace. So we maintain the transparency and openness of our communication. So every 10 a.m., the chief of, please next. Chief of the Korean CDC reported every day for the every details of Korea, confirmed patients and their movement route during past 2 weeks. And we send a prompt disinfection and a strong recommendation for self-quarantine for 2 weeks. And if there is a confirmed patients, we have ordered the hospitalization to the negative pressure unit. Sorry, I cannot handle it. So we experienced a very painful epidemic of 60,000 confirmed people in 2 weeks, but we didn't block that area, and we just trace and then follow and complete enumeration survey for every confirmed 60,000 people in these 2 more weeks, but we did. And then we get, although our hospital is located in Seoul, we get the patients from Daegu area after the genetic test. And if the test is negative, we can get an admission and do the elective surgeries. Next. So now we can do then 20,000 genetic tests for COVID virus every day. And comparing to the SARS virus for 14 years ago, Korea only has 100 tests at the time. So our testability is improved now. We have 5 very competitive companies and 45 more companies who want to develop their more fast testing machine. Next. So this is our drive-through test. So maybe I'm very proud of that. This is the first drive-through test area with it near my hospital. So the hospital president gathered the whole idea and established the safe quarantine area in their car, and the medical staff just swab the throat and the nose to check the test. So it takes only 30 seconds to have one test, and the result we can send 4 hours after the test. Next. We developed more to working through tests based on the idea of a virus handling in the laboratory. So the doctors don't need to change their level D protective clothes, just change their gloves and put into the patient's area, which is a strong negative pressure. It makes some air clean. So it takes only 30 seconds to have one test, and the doctors can do the test for 40 consecutive patients in 1 hour. So one test for 30 seconds, and then 2 minutes for the air wash, and then we redo the test. So during the past 10 weeks, we experienced already for 3 different stages. First stage, containment. We have very nice, successfully maintained the virus spread out. At that time, we developed the diagnostic test kit. First 2 weeks, it takes 12 hours to have a result, but now we reduced the time for 3 or 4 hours. After we experienced the outbreak from here, we changed our policy. So only containment is not enough. So never underestimate this virus. This virus have more than 3% of mortality and very fast spread out ability. So it's really different from other coronavirus. So we realized how bad this situation is. So we changed it to our policy to mitigation and maintaining containment. Next. So we developed many infographics. If you come to Korea, you can see every photographs and every infographics everywhere for social distancing and for protecting virus, the big campaign. Next. And then we developed our app. So if the confirmed patients, as our CDC open up their whole route in the past 2 weeks, and then if the people go this area, this app automatically warned that this area is contaminated 2 days ago. And then we have some manual for 6 hours of disinfection. The shop or restaurant can reopen, and then people can believe the ability of disinfection. So our economy still maintained after very strong disinfection only for 6 hours. Next. So in the mitigation stages, so we established a novel triage. So next. We understand the virus, 81% don't have symptom or very mild. So we should protect the hospital and the medical staff first. So the mild patients don't need to get an admission. So we send them to a community center, not a hospital, because our country have a limited ability of the bed. So maybe 14 patients of severe who has pneumonia and some high fever, we send them to the public hospital only for the coronavirus. So we make make some empty for every patient and then make some public hospital only for the COVID virus. And 5 patients is very critical. So we send them the national designated hospital and the tertiary very big hospital, because our aim for the 5% is save the life, so decrease the mortality. So this is our triage. Next. So this is another algorithm. If there is any doubt, test. If there is any screening, if there are any doubt, test. So this is our ability to reduce the virus speed to spread out. Next. Next. So we always check the ability of the empty bed. This is the yesterday situation. We have 3 beds, very intensive care unit, 7 another intensive care unit, and 432 beds. So who have confirmed patients, I can send that hospital. If you click this hospital, you can send the patients to this empty bed. So public and private hospital coming all together to make some same strategy against the COVID virus. Next. So this is Myeongji Hospital. We have 12 national designated negative pressure units. We have 8 more ICU unit only for the respiratory patients. Next. We have every day multidisciplinary meetings, because if the air is contaminated, in the COVID confirmed patients and the normal patients mix in the same area, so we can divide it. So there is no safe rule. We always discuss, and we always set up a new rule and manual to understand, even for the non-medical people to understand. Next. Next. So we established it outside of the patients to the screening center. if there is any doubt for the COVID virus, so we never let the patients enter to my hospital. So outside of the hospital, we can establish the OPD based. This is for the respiratory patients, and emergency based. This is for the very strong screening area. Next. So this is our building for the trauma and the infectious disease only. So we developed 3 different buildings. The separate even air and the medical staffs never mixed, because only this COVID area, every medical staff deal with the COVID related jobs, and this safe area, they can maintain some elective surgeries and on other patients. Next. So we completely separate this area. If the patients want to come into this safe area, they should get a virus test 24 hours before admission. Next. What about the orthopedic surgery? So first containment, we are open for the visiting observers and everywhere, because at that time for 4 weeks, Korea is very safe and successfully controlled the COVID virus. Next. After we experienced for epidemic crisis, so this time is a very painful, embarrassed period. So no elective surgeries. Every hospital was shut down for 2 weeks, and we think about what to do. So how can we deal with this very dangerous virus? And then we find a way of new strategies. The basic is a trace and test. Next. So third stage, we can get into the mitigation stage for routine coronavirus test. So we divide completely to our hospital for COVID zone and the safe zone. So every new patients we meet in this area, if we confirm the patient is very safe, we transfer the patients to this safe zone, and never, even medical staff never enter this area. So we completely separate. Next. So we changed our medicine to the telemedicine system. But after surgery, so we can meet the telemedicine. Next. Even for the exercise education and training, we can use the SNS and the video course. Our exercise specialists to show them their exercise to the patients, not in the sports center, but via SNS and video. Next. And we have lots of protocols. We send these pre-made protocols to the patients. Next. And we have lots of training requests from overseas. Next. Next. So we decided to change our modality to the web-based education center. So we started to build a new hospital. This is the operating room. This is now a new operating room. We'll start 2 weeks after. So this is a Conmed Linvatec room. So we showed our live surgical demonstration and the real-time conversation with the foreign doctors and many other beginners to give some education. So we established our observation room. So this will be our future. Next. So I think, unfortunately, COVID virus will not end in the near future. So according to the specialist, more than 60 to 70% of whole population have have an antibody, this coronavirus will be ended. So maybe we realize that we should maintain very painful social distancing while maintaining our surgeries, educations, and even for the enjoy for the life. So this is our life for education, for OPD clinic, even for our dinner with some good food. They show their good memories and share in the web-based dinner. So next, this we call it new normal. So still we pray for our whole international friends. So in front of the COVID virus, we are one. We shall overcome against the virus. Thank you very much.
Professor?
Yes.
And Eric, while we are getting questions together, Professor, you say that patients who are going to be operated on get tested 24 hours in advance.
Yeah.
Because we have concern maybe they are in that 80% minimally symptomatic.
Yeah.
What do you do about your staff? Do they get tested as well routinely, or is it only based on symptoms?
Yes, for the medical staffs, we check the body temperature as a symptom and have an obligation to report every day, but not test every day. But as an hospital president, I did 3 tests until now because I move from the COVID zone and the safe zone every day. So I routinely check the coronavirus test, but not every medical staff. So they check for the body temperature and the symptoms. So medical staff are very sensitive for the symptom. So until now, for 10 weeks, we have 2,000 medical staffs, but we are very safe.
Professor Kim, thank you. One question from the audience. What indicators did the government and health systems see that made them feel comfortable resuming elective procedures?
Until now, unfortunately, the government don't have any regulation for the elective surgeries. So we, as a private hospital, Myeongji established our own protocols to check the virus test 1 day prior to surgery. Okay.
Erica, any other questions from the other physicians on the call?
It was a very clear exposition. So how many people are living in Korea, in South Korea?
We have 500, maybe 50 million.
50 million.
Yes.
And so they were all tested, most of them tested for the COVID? No.
Maybe until now
Yes,
we have
drive-through thing.
400,000. 400,000.
Okay.
400,000 tested.
So it is about 8-9%.
Not so many for comparing to 50 million. So it's only for only the patients who have some symptoms.
So only the symptomatic one are tested.
Yeah, symptomatic one, but we experienced some very painful epidemics. At that time, we call every patient of pseudo religious group. Every day, everybody. So it's surprising. So 25% who don't have any symptom has a positive COVID virus at that group. So close the society with the shouting, is very dangerous for spread out for this virus.
And I also noticed, but maybe I did not understand well, that visiting doctors are still allowed in the elective surgery in phase 1.
Yeah, in phase
we were
1,
immediately forbidden to host anyone in the hospital other than people really working there.
yeah, as in phase 1, during 4 weeks, we had only 30 patients. So we realized COVID virus is nothing. And at that time, frankly speaking, we underestimate the COVID virus. And after we experienced the 1,000 patients with only one infected patient for 2 days, so this is a very dangerous virus. So we changed our policy.
Yeah, so it is coming the same kind of message for our friends who are not that much involved. Please do not underestimate it. Because if you are facing this, face it strongly from the beginning. Is that right, Professor Kim?
Yeah, so I do agree your recommendation.
Can I ask both visitors?
Kim.
Go ahead. Erica, one quick question.
Dr. Abrams. Yes, go ahead.
We are trying to anticipate when we think that it would be safe to start doing elective surgery, maybe in a location different than the hospital, as Professor Kim has suggested. Does this relate to flattening of the curve or demonstrated improvement in decreasing the number of cases? In other words, what would be a signal to the surgeons that we can start considering doing some work as we used to do, but maybe not in a hospital location? Is there a statistical point where we have some indication that we can consider this? We have just learned in our country that the end of April may be the time that some of our businesses start beginning again. But this does not necessarily talk about medicine. This may talk about restaurants or other social with spacing maybe. So what I'm looking for is people refer to flattening of the curve. I think that this is more of a hospital statistic to see whether hospitals become overwhelmed. When do doctors start doing doctor work that most of us are familiar with? Flattening of the curve or improvement, assuming vaccine is a year away or more?
So it's very hard to answer. We need to open up the discussion. According to our specialist, so our school for high school and middle school can start again if our community has positive confirmed patients less than 50. That means our society infection is getting definitely decreased, but Korea is not reached that level. So we delayed open the school. However, the hospital, we have to see the very dangerous patients, not only for the COVID virus. So we, our government and the insurance can cover every diagnostic test at this moment that they allow to test. So maybe the hospital can open, and if we confirm the patients is very safe for the COVID virus, we can do then elective surgery and admission. So my recommendation is re-establish the safe hospital and the safe medical staffs to do the elective surgeries and practice, and then divide that with the COVID handling area.
Jeffrey, to your question, that is, of course, the most important, but at the same time, the toughest question that nobody has an answer. The rumors that I hear in my hospital, and it is very much linked to the structure of the hospital, is this one. When the curve is flattening, we have 9 different buildings, even far away from them. A couple of them are totally empty from the beginning, closed, locked down. Nobody's getting in and out. And the plan of the hospital is that they will reopen this to elective surgery, allowing only the patient to get in. But still, flattening and continuing the prevention, avoiding or reducing as much as possible interactive contacts between people. But again, this is not a rule. This is also related to the structure of your hospital, Professor Kim Hospital, my hospital. They have the chance to do so. They lock 2 buildings, big buildings. They keep them clean, empty completely. And when we start again, they will start with the same way. We do the checkpoint at the entrance, as they do everywhere, like in Korea, in Italy, everywhere, checking temperature and so on. Only the patients are admitted, and the family will be kept outside. This is the general plan, but it is a very rough description and very much related to the structure of the hospital itself.
Helpful. Thank you.
A couple of questions from our chat box. What precautions, if any, do you take during intubation and extubation?
You mean intensive care and sub-intensive? Did I understand well? Intubation or not? Was this the question?
Yes.
I believe that this is more related to if you're doing surgery, let's say if you're doing a fracture, if you should be there during the intubation and extubation, or if you should try to basically stay away during that time and then come in when everything is done.
These are more than rules, it is just good sense.
Yeah, I've read that there's some information saying that ideally you don't want to be in the OR when they're intubating the patient or extubating the patient, so try to come after all that's done, and only the anesthesiologist should be there at that time point.
Yeah.
So the few cases we've been doing, it's exactly what we did. We only came in once everything was done and set up. We stayed out of the room until then.
By the way, now Erica has the book in English that I got from Adam and Joao Paulo, and also from myself. So eventually, Erica, you can distribute to everyone participating in this WebEx this book that is very nicely written about how to manage.
Thank you. I will definitely share that.
It is
A question for the panel.
Yes.
Perfect. What are your thoughts on elective surgery potentially increasing the risk of COVID-19 related to immune system, blood loss, etc.?
It's very hard to give an answer. So I don't think elective surgery will increase the COVID virus risk factor, but in admission, if there is one confirmed patient, maybe one whole block should be confined. So maybe before admission, you should confirm the patients had COVID virus or not. So although we have 2% of false negative in the virus genetic test, so 98% we can screen. And then we check the symptoms and the temperatures, and we should do our best to protect our hospital.
Erica, real quick, I don't think we know what constitutes good resistance to infections like this virus. We really don't understand. But one thing you do know, comorbidities is a major problem. Diabetic patients, people who come to the operating room with other medical issues clearly can have a bigger problem if they're even introduced in small volume. So I think rather than blaming anesthesia or surgery, because we don't really understand, we've all seen patients come out of a long operation, they look quite good. But I think this relates to comorbidity that the patient has before the surgery, not necessarily the anesthetic that's applied or the surgery that's applied.
It's very appropriate.
And thank you. One more question from the group. Professor Kim, do you feel that life is returning back to normal now in Korea, or are you still seeing lockdowns and quarantines?
So Korean society is not locked down. We can manage the virus successfully. However, I don't think our society is safe. We cannot return back to the past safe period. So we doctors established the idea of a new normal, maintaining distance, some painful separation, and protection against the virus for a while, more than 1 year, and re-establishing our lifestyle. So we developed the more electronic and the more web-based conversation and communication. So we continue our discussion to the economic development. So we should go ahead for the new way of life. So COVID virus can change many things in our societies.
We have a couple of additional questions. I know we're slightly over the time that we were projecting, but if our panelists don't mind, can I ask them? Thank you.
Sure.
In Italy and in Korea, have you seen any shortage of PPE, like gowns and masks? And if so, how are you handling that?
I'm sorry, the sound is rounding.
What is PPE, Erica?
Personal protective equipment, so face masks and
we call them DPI. Yes, it was quite a fight to get them, because all of a sudden there was a very high request, and so there was, and all the storage was sold out in 1 or 1 week or so, and then there was down, and now nothing is going back to normal. But imagine that, for instance, the gowns now are done by one of the factories of Armani is doing this. Yes, seriously, they started producing this. They converted the production. A major company dealing with steel, now they are producing the bottles for oxygen. And what else? The ventilators, even Ferrari, the company, they produced something for the engines, then diverted the part of the factory to produce this. But there was going down, no more storage of this stuff now coming back. Because it was really unexpected.
Ferrari.
We had Ferrari ventilators, gowns by Armani, very typical Italian.
Yes, so we Korea experienced the similar because our protectors, goggles, and some gowns are all imported from China. But after China lockdown, maybe the Korea has some embarrassing period to overcome this painful shortage of this protection. So we started to make by ourselves, like Samsung and Hyundai, make some masks and some level D protectors, and the small companies started to make some goggles. So now, we can supply the whole our protective devices. Unfortunately, until now, we don't have enough materials to support to other countries, but we still develop to help other countries to make our ability more and more.
And on top of that, very sadly, I should mention that also politics is negative influence in this. I tell you an episode about the mask. The Italian government ordered, I don't know, 10 million masks to a company somewhere in Turkey, and they paid it. And the company sent it to Istanbul to be delivered to Italy. And Erdogan, the government, stopped it. Ordered, paid, they stopped it. Just to give you an example. And probably there are many others behind that. That is very, very sad because, okay, I just report you the fact. You can draw your conclusions.
Thank you. One final question, and then we can go ahead and close this session. I did try to read as many of the questions as possible, so please forgive me if I did not get to yours. Once this crisis is over, do you all expect to see an increase in elective procedures, or are you more expecting people to be skeptical of even going to hospitals or surgery centers at all?
I expect that after 2 months, so maybe many countries can overcome this COVID crisis, and we will increase our ability to have an elective surgeries and many medical practices. However, the COVID virus is not the end. So maybe if the northern area have some summer, the southern area have some winter, the COVID virus move down and then relapse to next year. So we should prepare some small epidemics should happen everywhere. You should aware of these epidemics and then maintaining our routine surgeries and practice to protecting against the COVID virus.
Well, in a short and mid-term, I'm expecting declining elective surgery, but then recovering to normality. I cannot tell you a timing, but let's say that late this year, I'm expecting to be close to normality. And staying on what Professor Kim said, we expect at least for early next year to have a vaccination system that will be. So this will completely change the rules. But we have in front of us quite a few months of some reduction of our activity. But it is
I would agree with that as well.
Just a gut feeling.
I think some of it will be also related to the recession we'll be facing economically. So people will not be as willing to take time off of work when they're trying to get back as they would recover from after surgery. So I think partially economically as well, there'll be a dip for the short to medium term.
I agree.
Okay, I agree. Yeah.
Erica, just to let you know, thank you for Conmed Linvatec organizing. Thank you for our guests from Jorge and Tom and myself. This was enlightening, and certainly the future, however, may be 1 to 2 weeks away. So this is extremely helpful. Thank you for all the participants and the organization of this meeting.